Okay, let's make sure we got everything ready here. And I'm going to send a quick tweet out here just to kind of share this out.
I'll tell you what I think happened after.
Okay. So we are live on all the channels right now. And everybody, we're going to get started in just a minute. Okay. Hello and welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA Wrap. I'm your host, Raj Gupta, and with me today is my co-host, Gary Schwartz. Gary, how are you?
How you doing, Raj? Good evening. I hope everything is well, and congratulations to you and Vanderbilt for opening your new outpatient surgery center. That must be pretty exciting.
Yeah, thank you. We've been, anytime you're doing something new, it's always a new challenge, and I've got the privilege of trying to make that thing run as well as we can. It's always a new adventure, but a new set of accomplishments as well. So I'm excited about it. We're doing well. We're about 1 month in. We had a week of ice and snow last week, so I called it our practice crisis management week, where the whole staff and team had to come together, figure out how to make the place work while we were dealing with people who can't drive anywhere. In Tennessee, we have like one snowplow and one salt truck. So the whole city pretty much shuts down when there's 2 snowflakes in the air. You put 2 inches of ice on the ground and 3 inches of snow on top of that, and the city really struggles for a while.
I saw on social media that you're a great snow angel for someone who doesn't get a lot of practice. I was pretty impressed.
Hey, snow angel's pretty low threshold skill, I think. So, hey, before we get started with our topic today, I do want to apologize. A couple of the other people we were going to have on today, we've had some scheduling conflicts, so we weren't able to get them on. But I think that Gary and I have a good understanding of the topic, and I think we'll have a good conversation. But before we start, I want to point out a couple of things that are really important that are happening with ASRA. Obviously, this year has been full of change, a lot of weird stuff going on, and so scheduling and expectations, things like meetings, are difficult and confusing and unpredictable. So we do want to remind people that the spring ASRA meeting is coming up. And, we didn't have the spring meeting last year because the pandemic. Let me pull up the webpage here. We didn't have the spring meeting last year. It got canceled. The fall meeting was completely virtual, and they did a spectacular job with incredible attendance at that fall virtual meeting. But this spring is a combined in-person and virtual meeting, meaning that you can attend the meeting in person in Orlando at Lake Buena Vista, Florida, right at Disney's property there. Or you can attend virtually. Now, there is a little bit of a difference. Obviously, you can do some things in person that you won't be able to do in a virtual attendance. The fees are also a little bit different. But we want to make sure everybody feels comfortable with attending the meeting, whatever they feel safe for them and their family. And so ASRA has created both opportunities. And so I think this is going to be a really exciting thing. I know all of us have been craving getting together and meeting and talking about this these acute pain and regional anesthesia that we love. And so just put this on your calendar, May 13th through the 15th. Registration is open right now. If you want to submit abstracts, go to the website and then find out what you can participate in. We'd love to see you in person. I'm going to be there. I think, Gary, you're going to try to be there.
I registered at my hotel room already, so I'm excited to catch up with our colleagues, learn from in person and virtually.
Yeah, so we get to do a little bit of both, and we will hopefully see everybody there. I think it's still going to be a great meeting. There's going to be a lot of your favorite people there, so come if you can. Join us virtually if you can't. We understand both ways are going to be a good experience. So that's the first thing. The second thing is that ASRA and this is what we're going to be talking about right now. So, I think most of you guys know that I've been a big proponent and a big contributor to the ASRA apps that ASRA has pushed out. And ASRA has been sort of a leader in this area in the anesthesia world and creating content from the society side and publishing it for the users out there. We have ASRA COAGs, timeout checklist app, the local anesthetic toxicity interactive app. Well, one of the more recent apps that ASRA put out is CODER. And CODER is the one that we're going to be talking about today. There's been a big update to CODER that just came out. If you installed the first version, it was a very much a first version. There was some bugs in it. There were some content issues. ASRA took all that feedback and revised this version. So I highly encourage you, maybe you have to delete the old version, reinstall the new one, but go to your app store and get this new one. That's what we're going to be talking about today. Before we jump into that, I don't want to miss one really, really important thing. And Gary, I want you to talk about what you're doing tomorrow morning.
So tomorrow morning, I was invited.
This is really special. Yeah, this is really special. Listen, people, because I want you to put this on your agenda for tomorrow morning.
I was pretty excited. So tomorrow morning, one of the hosts of the cardiac show, Greg Ribicoff, who is a world-renowned heart surgeon in New York, co-hosts Doctors Radio on Sirius XM. I believe it's channel 110, and I'll be the co-host and guest tomorrow between 6 and 7 in the morning, but it will be replayed in case you do not want to get up at 6 a.m. Eastern Standard Time. And we'll be discussing all different issues relating cardiac pain, interventions for cardiac pain, including regional anesthesia, talk about some of our colleagues' wonderful articles, and also for persistent chronic pain after cardiac surgery. He's a forward-thinking surgeon who has adopted numerous EROS protocols, multimodal strategies to improve efficiency in the cardiac OR. And I'm honored and privileged to be his guest. And I'm super excited for tomorrow morning.
Yeah, I think that one of the things that I've learned over the years is that this collaboration between surgical teams and anesthesia teams as we're figuring out plans forward is the best way. We've done this a lot with our total joint and orthopedic surgeons, but cardiac surgery has been a venue that regional anesthesia sort of shied away from for a long time. And we're starting to have options for how to deal with pain related to cardiac surgery, which we haven't really had for a long time, anticoagulation concerns being one of the biggest issues. But with the advent of fascial plane blocks and a lot of things that we can do to reduce the amount of opioids they require with multimodal analgesia and then dealing with chronic pain, I think that cardiac, the relationship between regional anesthesiologists, acute pain physicians, chronic pain physicians, and cardiac surgeons is another really great relationship I think is going to be wonderful. I think it's spectacular that you get to speak on this topic and really share our perspective as anesthesiologists to a community that maybe doesn't get to hear about that.
I'm really excited for tomorrow, and I'm super excited for the ASRA CODA. As you guys have known, Raj kind of spearheaded this along with ASRA to get these app-based programs to give people more access between the timeout, and the COAGs, which most anesthesiologists use on a day-to-day basis, that they added the ASRA CODER app. And a big special thanks, obviously, to Raj, but also the practice management committee, David Provenzano, Jay Grider, Kevin Vorenkamp, Jennifer Norenberg, and the whole ASRA team to make this a possibility with Raj. As he said, the last time was a beta test. This is an updated version, and it will update it yearly. You have to sometimes delete the app and then reinstall it, but you don't have to pay again. Your initial fee covers the update. So as CMS changes the codes, as they add different codes and RVUs and reimbursements, the app will update that, which is pretty important.
So Gary, let's break this down, because I think a lot of people probably don't even know this app exists. So I'm going to put this back up on the screen and show people. So, and first of all, before anybody gets any weird notions, this is as a conflicts of interest disclosure. I don't get anything from this. I don't make any money from this. Gary, I don't think you make any money from this.
I've actually paid money to buy the app, just like everyone else. I didn't get a discount.
Right.
I make it, but I didn't even get a free version.
Yeah, I was in the discussions of the early development. I don't take full credit for this at all, because I know there's a lot of other people that did most of the hard work. But yes, I too paid the money to get the app. I don't get a free version of it either. So I just want people to understand that this is not really a sales pitch, but more letting you know about a tool that could be really useful for your practice. Let me pull these little banners off so you guys can see this properly. So let's put this into context. I think the first thing is to understand why we need something like this. And the way to describe that is, let's talk about the world before this existed. How would you normally do your practice trying to come up with procedure codes, E&M codes, all this kind of stuff? What was your normal routine for that? Or what do other people normally do? How do they know how to do this?
Either talk to their billing company. They still have it, the ASA, the crosswalk with the relative value guide. You could look at that, but it's a pretty dense book. You can't search it like we're used to searching on Google or any sort of search function now. And it was very bulky and difficult to look through if you used to not have access to it. If you're nervous about a code, let's say me in the pain management world, if a code changed, you can't just call your biller always immediately to get access. And over the past year, as Raj brought up, in at least the anesthesia world, with all different nerve blocks and fascial plane blocks, those move to the chronic pain practice as well. So you have to know how to properly document and code the procedure to get reimbursed. In the end, we all want to take care of our patients, but we have to get reimbursed with our practice to purchase our ultrasounds and our needles, and obviously pay our staffs and our techs and everyone else. So a perfect example of this, a couple of years ago, we used to build genicular nerve blocks on other peripheral nerve codes, 64450, however many genicular nerves you blocked. Recently, and it's updated in the new app, it has its own code, 64454, where you have to block 3 genicular nerves and document it with image guidance. And there's a separate code for radio frequency. So if you were not updated to the app and your biller wasn't updated, or you didn't check you had the last year's version of the ASA relative value guide, you would miss this payment and probably not get reimbursed for your procedure, which is extremely important.
I'm guessing, and I'm not a chronic pain physician, so a lot of these codes this doesn't come into my practice very often as an acute pain physician in a big tertiary care hospital. I send off my notes and somebody else takes care of a lot of the billing codes. But at the same time, both acute pain regional anesthesiologists and chronic pain doctors in a lot of places, I'm guessing, instead of looking at that thick book every time and flipping through the pages, they probably made cheat sheets, right? You probably made a little note card or something like that with your most commonly used codes. And early on, chronic pain 10 years ago, that was probably fine, right? Because you're probably doing 10, 15, 20 procedures at most at any given time. And now, at least in chronic pain, the number of procedures you guys perform with the variations and the different approaches and the different treatments and stuff like that, and you start multiplying those permutations out, you're talking about hundreds of potential codes. And once you establish what those hundreds of codes are, then it changes every year. It's updated. I don't know how you would keep up.
There's no way to keep up. Let's say one of our colleagues, Jeff Gadsden, just wrote an article in Anesthesiology News, how they use genicular nerve blocks for their total knees now at Duke, I believe. So if you didn't know you have to document 3 nerves, your coder, if you forget to document it properly in the note, your coder is not going to know what to bill.
Right. So even if you don't have to write the code itself, you don't know what the content of the documentation needs to be to hit that code.
Exactly. You can't just write genicular nerve block ×3. You have to document which genicular nerves you do. And it's a simple fix, especially as all of us, you just implemented a whole system in your outpatient surgery center. You probably have a fancy EMR. It could be easily added to your advanced MD or Epic system to have the documentation, what you need, so you could properly document what you did for the procedure, which is in the best interest, obviously, of your practice and also the patient.
Yeah, one thing I want to show people, and I know this screen may be a little hard to see, but the way you kind of navigate this is that there's a variety of ways. So the front screen of this app, and by the way, before I forget, we have a question here. It says the platforms. Marcelo Vaz Perez is asking what platforms. I'm assuming he's asking if they're iOS and Android. It is available on both Android and iOS, Marcelo. So you should be able to get it on either platform. It is not a web-based thing. It is an app download that you have to get because the content actually lives in the in the app itself. It doesn't rely on an online connection to a database. So that's the nice thing because you don't have to be online to get it, and it's instantaneous. All the content is built in. So procedure type, evaluation and management codes, and here's the thing: ICD-9 code or ICD-10 codes. But my favorite 2 things is one at the very bottom. There's a search box, So if you don't want to navigate the tree of stuff, you can just search for something. And then there's this section called favorite codes. So as you go through these, and if you look at this third image, up at the top right corner, there's a little star. And you can star that, and it becomes part of your favorite code. So that becomes like your cheat sheet that you made, that little note card you used to keep in your pocket, but it's live, so that the next year when they update the app, you've got your favorite codes, but with the new information in it. And the list can be much longer than you could carry on a note card. And so you can really start customizing this to your own needs. And then when you dig down into it, there is a short version of the information that you need, but then there's a longer, more detailed version. And that has all the nuance about the code itself. What are the coding tips? What are the variations and related codes? What are the exclusions? What are the inclusions? What all the little details you need to know. And then it actually takes if you dive down even further, you can actually see what the reimbursement and RVUs are for both facility and for professional fees for these codes, and what the little variations mean as well. So incredible amount of detail, lots of detail. And we actually, ASRA actually employed and hired a professional biller to create the index and database behind the scenes, so that this stuff is super accurate by somebody who knows how to do this well. And it wasn't just something that we kind of muddled together. The structure was designed to be user-friendly. The content was designed to be accurate and deep. And I think that's really important for something like this.
And I think it's also important for you to learn what you're getting reimbursed for certain procedures, what you do. Let's say, unfortunately, for a lot of our procedure base that we do in regional anesthesiology, starting April 1st, we're going to get a decrease of, unfortunately, 2 to 3%. Medicare is definitely negative 2% reduction starting April 1st, which was paused for the pandemic, which is important for our practices, especially. I know a lot of academic institutions, maybe you got your travel budgets decreased, or in private practice, maybe your salary decreased, but it's important to know why, because a lot of the insurances follow CMS and a lot of our patients are reimbursed by CMS. It's also important to have an idea of what we're getting reimbursed overall for each of our procedures, as we ask maybe our facilities for new ultrasounds or different type of block needles or catheters or different medications like liposomal bupivacaine. Is what are we getting reimbursed? Where's our value? Also, you can see what the HOPD, which is what the hospital is getting reimbursed for some of their procedures, versus what the physician is getting reimbursed, which I think is important for trainees and anesthesiologists, even people who've been working 30 years. It's important to know your value, or at least what the hospital thinks your value is.
Go back to that point a little bit about the trainees, because I think that, I think only recently really do trainees get proper education, and not even only sparsely, about things like billing, coding, and then how to negotiate with their practices based on that information. Again, if the CMS rules have changed and the professional fees have gone down and the hospital fees have gone up, then you negotiate very differently as far as who's picking up the tab for what part of the process, right?
Exactly. It's important to know your value and what everything has a price and a value to it. So it's not only for new grads in the pain world and the regional anesthesia world. I spoke to a colleague, I was mentoring him a couple of years ago. He was taking for an interventional pain drug right out of fellowship. And the hospital was offering him a certain amount of money. And they were saying, oh, you get X, Y, and Z for each epidural done in the hospital. So we went over some of the codes, but for each epidural, let's say Medicare reimbursements $97 for an epidural on average, right? The hospital's like, oh, when your salary, you're only bringing $97. And then he was able to say, okay, but the HOPD fee for each of my epidurals is $700. So I'm actually bringing in, if I'm an employee of the hospital, not $100 per procedure, $800 per procedure. So I want a nurse for my practice to help facilitate this.
Correct.
Which is your true value. So let's say if you could open up an outpatient surgery center.
Yeah. I've heard of those.
Multiple total joints, even up to age 80. And have all successful outcomes. And let's say you might only be getting on Medicare average, let's say 60. I'm just looking at the app right now as we're looking. A single shot, let's say femoral nerve block in the facility of, let's say, $53. But you're able to discharge the patient faster. They're saving on their fees from that. And the hospital gets an HOPD fee of a few $100s. Maybe Raj Gupta does not buy the new ultrasound, but hospital X buys the new ultrasound because you're showing them value.
Yeah, I've been having that argument with our leadership for years, but without the numbers. I just made a lot of assumptions about who's making what. And I was probably underguesstimating how much our hospital was making on a lot of the work that we did. But I knew that it was more than what we were making. I remember early on when I was running our acute pain service that we were looking at billing codes and why our group was losing money in the hospital acute pain service, regional anesthesia service. And partly it was because we weren't coding properly. We weren't documenting properly to capture full coding. So that was a lesson learned early on. But the second is that we realized that we are almost a loss leader in certain circumstances, but we facilitate early discharge. We were discharging people on average 1 to 2, sometimes 3 days earlier than what they were before we were doing regional anesthesia. And so if you look at these billing codes and you go, okay, you make $90 or $150 on something, but the hospital saves 3 nights in the hospital and they're still making the same amount for that surgery, well, okay, all of a sudden the math of your value changes very fast. And not to mention how much they make off your block itself as a facility fee.
Yeah. Hospitals are still going to look at this again. April 1st this year. It's not that far away. Right before tax time, the 2% Medicare reductions are set to rephase in, and unless there's a congressional change, you don't know what your administration is going to ask for in terms of reductions, or maybe the next year after you negotiate your salary. So you want to see your value for all these other codes. And I don't mean to all talk about dollars and cents. That's not what I'm trying to do, but you have to pay your staff. You have to be able to hire adequate staff. So with the app, you're able to make sure you're documenting and getting reimbursed for all the procedures that you're doing. You would hate to do the proper, let's say, regional technique for a case or interventional pain procedure, do everything that you were supposed to do, the proper imaging, and not get reimbursed for a lack of documentation that you could easily pick up on the app, or worst case, overcode for something that you weren't supposed to bill for and then get dinged in an audit later on. So
yeah, the accuracy is super important.
And I think that's one of the big advantages. And the thing that I use in the app a lot, because I do regional anesthesia and pain, so I can't remember all the codes. I get a lot of them off the top of my head, but it helps me, especially for the sparse procedures, or for some reason the genicular RFA code just constantly blanks my mind. So I could easily search it, see that it's 64624, know that I have to document 3 genicular nerves with imaging for the radio frequency so I can get reimbursed with my practice. And then when this changed in 2021, it already updated in my app. And I assume the app's going to update the same way in 2022, or if the Medicare payments don't go into effect, the app will show that. So I think that is very helpful. And it's good to see how they reimburse you, the hospital, and just how many codes there are for each procedure. Like there's a different code for a femoral nerve block single shot versus continuous catheter. Yeah. And you want to see what the biller is looking at so you know how to set up your documentation, especially if you're a new trainee or a fellow. You want to see if you're going, let's say you're going to start a regional program or a pain program at a new institution or an offshoot of a hospital. You want to see how you want to make your notes and get your documentation down to have everything proper for reimbursement.
Yeah, and there's a lot of ways to template a lot of that documentation if you understand the nuance of it, so that it becomes easy for all the providers in your group to capture. Again, not you're not trying to take advantage of the system. What you're trying to do is get credit for what you did, and not lose credit because of a checkbox that wasn't checked properly, or a little documentation line item that you forgot to say this one phrase or something like that you did, but you forgot to write it down, or you didn't know you were supposed to write it down. And I think that understanding is really important.
And that's what it's going to come back to. Let's say, for an example, if you don't realize this, like you're going to have a coder on your billing company, and CMS is going to look the same thing when they reimburse it. If you document 2 genicular nerves, you're going to get paid for 1 other peripheral nerve block and about half the other, which is about a half to a third less than doing the 3rd nerve that you blocked and getting paid for your full genicular nerve block. So it's really important. And people say, oh, what's this money and what's that money? Well, it's the addition of hiring new staff or getting new capital equipment. But the better you are at documenting and getting reimbursed for what you actually did, it allows you to hire top quality staff. you at your new institution or your new ambulatory surgery center, you probably only hire the creme de la creme. So you set your system up straight. It's probably all, you use the app, you probably set up all in your Epic system or whatever your EMR is to capture everything that you do, which allows you to hire the best and the brightest to keep your center working.
Yeah, we spent a lot of time making sure that our documentation templates and macros include all the necessary details, and then we train all our people to make sure they do the necessary components and try to capture that detail. So, and then we standardize across personnel so that each person isn't coming up with their own note, and that speeds up the billing and coding process. And our coders, I mean, our coding staff, they can pick up missing elements really quickly because it's all standardized and uniform and predictable. And so if this one little checkbox isn't there, they send us a message, say, hey, you're missing this checkbox. Your code's gonna drop from this value down to this value because of that one little thing. And so they can send that to us before we send off the bill to CMS for reimbursement. And you mentioned we recently just bought brand new ultrasounds for that facility, and I actually managed to convince them to get us the upgraded ones because we knew we were going to be doing a lot of blocks, and we show our value in being able to do that with high quality equipment and high quality care.
And I think that's important to realize. And you also have to realize, again, like the E&M codes, which is our office visits that we see in the pain office, or if you go to your primary care, have an increase in payment for 2021, which means, unfortunately, a lot of our procedures do have cuts across the board. I'm just glancing now. This is not part of the app. This is just in general on ASRA.com, which they just opened the new website today. It's redesigned. It's actually pretty easy to use. And they have an update on this. And we could see a lot of our blocks.
Let me put this up on the screen so people can see.
Oh, thank you.
This is the page, right?
Yeah, that's exactly the major changes in Medicare physician payments. And they go over, like, unfortunately, femoral nerve block single, 64447, which I got from the app, net less than 3%. Lumbar plexus, minus 2%. Axillary nerve block, less than 2%. Brachial plexus, less than 3%. It's important to know that you're getting decreases across the board. The other important thing of this, which I can't stress enough, I'm not part of it, but the RUC committee, you sometimes get an email from the ASA if you're a member to value your code sometimes when they look it up before the RUC committee. It's important to fill this out because the ASA has a representative. I believe it was Dr. Rosenquist, either last year or 2 years ago. And they go with all the value, like how much time does it take to do your procedure? What equipment do you use? I don't know if you got the ASA survey before. And this is what they bring to Medicare, because Medicare is a big pie. And the pie is worth 1. And then they divvy out who gets what percentage and what's the increase. So they increase, let's say, me seeing a patient in the office for the pain practice, but unfortunately that led to a decrease in some of our procedures getting reimbursed.
Yeah, I don't think the E&M code changes are on this page.
They're on one of the pages on there. It's across the board. I believe it's on page 4 on a different article.
Okay. All right. I'm not sure. I don't see it here.
RVU increase. Sorry, I'm flipping through my paperwork on there. So it's also just really something to consider to make sure that we're getting all your proper coding and reimbursement. I think Jennifer Norenberg mentioned something on there.
Yeah, she said, we have to, everybody's got to code and submit properly, and it makes the C-suite presentation so different for us when you understand your coding and submitting. But it's a preview of 2 speakers coming up again soon. She's kind of referring to a hot topics session that we're going to be part of coming up in April. I think, what is the date? April 13th? If I remember right. I think we're doing a session for ASRA, hot topic session on practice management. And we're joining Jenny for a session coming up on April 13th, I believe. So more details to come about that. So not to belabor the point, but I think that the point we wanted to get across for people on showing this is that, ASRA is really committed to helping its members, but also the anesthesia community at large. And one of the things that the organization has realized is that good tools, when designed well and implemented well, can make a huge difference to people's practice. We are inundated with a lot of information, and yes, you can find this information in other places. Absolutely, you can. But when we make it easy and convenient and user friendly, then it becomes actually something that you can implement without too much difficulty. And I think that's really important for people to understand about why ASRA has taken the time to build and disseminate these apps like coags, like local anesthetic toxicity last, and like CODER, is that there was a need, definitely a clinical need. The way that people were doing it, in this case, writing on a note card or flipping through a big book or doing a quick Google search, was either cumbersome or inadequate, and often not nuanced enough to handle the complexity that's coming up with this kind of practice. And so the need was definitely there. I think ASRA has done a fantastic job of building something that is extremely useful for many people in their practice. And I encourage those of you who maybe think, oh, I've got other people to do this for me. I've got coders, billers, people who handle all this stuff. I encourage you to dig through this because you'll learn a lot. And like I said, you can improve your documentation, which helps the billers and coders out. It also helps you with your negotiation, with your leadership, when you're trying to establish your value as a regional anesthesiologist, as an acute pain physician, as a chronic pain physician in that environment. And that way you're not getting sort of the short end of the stick.
One other important thing is you're signing the chart that they're sending to CMS. They're not paying Gary Schwartz, the biller. They're paying Raj Gupta, MD. So you want to know out what your billing company or institution is billing out for you to make sure that you're documenting properly, but they're billing out exactly what you do rather than billing out for something you're not. It's important in the pain world for the time E&M visits and the complexity of that. If you're doing a spinal cord stimulator trial, like I did a couple of them today, that you're billing for 2 leads, not 1, or that you're billing for the proper nerve block. So let's say a brachial plexus block, like an interscalene, is a different block number than an axillary nerve block. And you want to make sure you're actually documenting and signing off on your chart for the exact thing and the proper thing that you did.
Yeah.
Compliance is a big deal. It always has been, but it's even a bigger deal now with all these digitized notes. It's very easy to make mistakes. So it's good to delve in there, look, double check that you are putting the proper documentation that you need, because you're in the end signing off on the note. Like if anything ever happens, the biller is going to be like, oh, Dr. Gupta, Dr. Schwartz signed it. I'm just checking the boxes that they did this correctly.
Right. And they don't know the nuance of the medical component of that necessarily. They're just trying to make sure that it meets a certain threshold to send off to the next place.
Exactly.
So I want to wrap up a little bit. Any other thoughts or comments, Gary?
No, I love the app. I use it as a daily basis. Some of my staff have actually downloaded it because it helps for them. Because they used to ask me, oh, what's the genicular nerve block code again? Or, oh, what nerve block are you doing? Now they could just search on their own. And it's improved efficiency in our workplace for the staff and myself.
That's great.
It's good to have it as a handy tool. And I like to know when the updates happen and I could see the changes. And it helps to see if, let's say, one nerve block potentially pays more than the other. It's not a big deal, but sometimes you might be deciding between like a brachial plexus or an axillary, and you might want to see why one is the difference, and that's going to factor totally into your decision, but it's something in the back of your head to notice exactly too, if one nerve block potentially pays more than the other, and then you could add that to your side effect profile and your risk and benefits of why you're choosing something or the other, other than just, oh, it's arbitrary. I'm going to do it because I haven't done it in a while.
Yeah, and part of my brain is kind of turning, the gears of my brain are turning that, like we said earlier, we don't often discuss billing, coding, and this practice management stuff with our trainees, our residents and fellows. And I think this is a great sit down and chat conversation piece as you pull out the app and say, hey, let's search through some of this stuff and let's talk about the differences. It's a good starting point for a conversation that I think and is a great educational opportunity too, to dive in there and say, do you really know what the difference is between this? Do you really know that you have to document that? And I bet you almost none of them do.
And I don't mean to just talk dollars and cents. I don't mean to come across that, but in the end, we all go into this because of our patients. We want our post-surgical patients to do well. We want our hospitalized patients to do well. In my practice, I want my patients to have less pain and get more functionality. and I need to have access to these codes, document, bill properly, to hire adequate staff, to hire good staff, to allow myself, my team, I'm sure you do the self with yourself and your team, to have the best team possible to take care of our patients, which is what we want. And to allow us to do that, for you to get your upgraded ultrasound machine so you could do more advanced blocks to help out your patients, proper documentation allows you to do that, which in the end helps our patients more than anything.
Yeah, one thing I don't think a lot of people understand about medicine is that they look at us and they say, "Man, these guys are really highly paid. They make a lot of money for what they do." I know for a fact that I don't get paid for everything that I do. I know for a fact that there's a lot of work that's non-billable work. There's it's done on off hours. There's no time codes for it. There's no billing code for it. It's, chart reviews and talking to surgeons and doing all this kind of coordination and all this kind of stuff. And so, yes, and I'm happy to do it because I think it's an important part of my job. But those things that I do that are billable, that are codable, I should maximize that as much as possible so that I get credit for the work I've already chosen to do for the benefit of the patient, and not feel bad about that because that has to cover the expenses for a lot of other stuff that's going on as well, that maybe doesn't always get billed out clearly or exactly. So I don't think we should be ashamed or embarrassed about making sure we're documenting and coding correctly. It's more of, we've already chosen to do the right work. It's just getting credit for that. Again, going back to getting the value for what you do.
Exactly.
So I'm going to wrap up one more time, just as a reminder for people to go to the ASRA.com website, and I'll show this again. Don't forget, the spring meeting is back this year. I was in charge of the 2019 meeting. We had just a fantastic meeting in 2019 in Las Vegas. We were revved up and ready to go for a fantastic meeting in San Francisco last year, and obviously that didn't happen. And so I think there's a lot of pent-up energy, a lot of excitement. I think this is going to be an amazing meeting in 2021 in Florida. And again, if you can join in person, please do. If you feel comfortable, great. If you don't, that's okay too. There's a virtual attendance opportunity. You can join virtually and be part of the meeting and be part of the excitement from your own home or office. So I will be there personally in Florida. Gary's going to be there personally in Florida. I've already heard from a lot of other people that are going to be there. Come say hi to us from 6 feet away. We'll be looking forward to seeing you, and we'll talk more soon. But Gary, thank you for joining me tonight, and I hope you have a wonderful night. And remember, tomorrow morning on XM Radio, Gary's going to be on channel, what was it?
110, Doctors Radio with the fabulous cardiothoracic surgeon, Dr. Greg Ribicoff.
At 6 a.m. Eastern time.
There will be replays, though, for people who hopefully get to sleep or not at work at that time. And just one more thing is get feedback on the app so we can continue to improve. We'll always be updated with CMS, but we're always looking for ways to improve it just to help all our practitioners, pain docs, and anesthesiologists.
Hey, and you know what's really important about that? In all fairness, the app got some poor reviews early on, and it was sort of a beta version. So you see the star ratings, but there's only 3 ratings there. That gives the star rating a 2.3. And that's fair. It wasn't perfect at the beginning. It was the first attempt. But if you're using it and you like it, go show that in the reviews, because that helps other people understand that this thing's gotten better and it's more usable. And so it really pays off for ASRA to keep supporting this effort, to know that there's good feedback out there. So at least put the star rating. If not just the star rating, put a comment in there as well. I think that helps everybody out. Well, Gary, thank you. I'm going to wrap up. This was really great to talk to you. I always enjoy talking with you as well. And hopefully we'll be getting together for another podcast here soon. I've got one sort of in the works that I'm trying to coordinate with Eric on what's the appropriate sterile procedure for peripheral nerve blocks. Like how clean is clean, how sterile is sterile, and what's overboard. So I think that's going to be an interesting conversation. If any of you guys have any thoughts on that, you can send me a message on Twitter at Dr._Raj Gupta, and we'll put it into the queue for the conversation. I know there's already been some dialogue on that topic on Twitter this last week. So that's what got my brain thinking that it might be a really interesting topic. I hope to have like a whole 6 or 8 people up here so we can scream at each other about what's good and bad and hopefully get something out of that.
Can't wait.
Yeah. All right, man. Talk to you soon. Thank you, everybody.